Thank you very much for that kind introduction. Thank you to the Gulf Society of Cardiac Surgery for the privilege of presenting at the inaugural meeting, and congratulations for a wonderful meeting. Today I will talk to you and give you some of my personal insights into VAD experience with RV failure, and the question posed to me was RVAD or not. I have no conflicts to disclose. So the objectives are to quickly define scenarios of RV failure that may benefit from RVAD support, identify RVAD options. I'm going to focus on temporary RVAD options and discuss some risks and benefits, highlight the pathophysiology of a very common scenario, which is RV failure after LVAD support's initiated, and explore the outcomes of RVAD support, temporary RVAD support, as opposed to the more durable support that we heard about from that fantastic talk after LVAD implantation, and then share some of my personal strategies to support the right ventricle that is vulnerable perioperatively after LVAD implantation to minimize, not eliminate, but minimize the need for RVAD support. Right ventricular failure is a complex pathology that is often overlooked with a number of contributing factors, and I would refer you to this fantastic New England Journal paper discussing and reviewing right ventricular failure, focusing on precipitating factors such as excessive preload, excessive afterload, reduced lusitropia, and reduced inotropy. A pragmatic approach to temporary mechanical circulatory support in acute RV failure has been recently published in the Journal of Heart-Lung Transplant, and I would refer you to this fantastic document as well to guide you in this topic. We've heard about some of the more common echocardiographic and right heart catheterization parameters that would be indicative of right ventricular function or dysfunction, and so we typically base our judgment on the severity of right ventricular failure, both clinically but on these different parameters. The typical scenarios of right ventricular failure that we see in clinical practice are predominantly acute RV infarction, post-cardiotomy RV failure after cardiac surgery due to a variety of factors such as poor myocardial protection or compromising the right coronary artery. Pulmonary embolism can result in RV failure, but this is most usually a very, very acute situation with hemodynamic compromise resulting in the support. If you're going to use mechanical support, it's usually ECMO. And then what we find is a more common scenario amongst the heart failure group of patients is right ventricular dysfunction after initiation of durable LVAD support in a spectrum of severity. This slide and table from that review article from the Journal of Heart-Lung Transplant talks about the mechanisms of RV failure. The mechanisms can be related to excessive preload, excessive afterload, or reduced inotropy itself. And just bear that in mind as the three factors that can contribute to RV failure as we move along in this talk. There are different RVAD options that are temporary that are available on the market. You see in the upper left-hand corner the Impella RP, which is inserted through the femoral axis, femoral venous axis. The Impella RP Flex is the next one over, and that's inserted through the internal jugular axis. And then we have these other devices that are attached to external pumps, such as the Centromag, that can be hooked up in the form of percutaneous access through a Protect Duo cannula. You see down here. The surgical RVAD implantation through cannulation centrally, or the right ventricle can be supported and offloaded using VA ECMO. These cannulations can be either peripheral or central, and the advantage for the surgical RVAD and the Protect Duo is if there's compromise in ventilatory parameters, that an oxygenator can be spliced in, providing it more versatility compared to the Impella devices. Once these devices are instituted, we follow patients, and because these are temporary devices, we have to decide over a period of time whether they can be weaned and explanted, or whether there should be some consideration of upgrading to a more durable solution, as we heard in the previous talk. These are based on clinical parameters, hemodynamic parameters, echocardiographic parameters, and laboratory parameters. And so once these particular targets are achieved, a weaning trial can be entertained maintained. When you start weaning, this particular document and state-of-the-art review gives you a framework to frame the weaning process for these different temporary devices, the Impella, the Protect Duo, VA ECMO, or surgical RVAD, to guide you on whether the metrics for success have been achieved and whether explantation can be considered. Now, if you go into the literature is littered with case reports and small case series of the use of these temporary devices. There's no large studies looking at the use of these devices. However, more recently last year, a systematic review led by Shelley Hall's group was performed looking at the safety and efficacy of the Protect Duo approach to right ventricular assist in a temporary fashion, which is becoming more and more favored and commonplace. They looked at the best quality retrospective articles that are out there, and as you can see, as indicated in the yellow, the combined study sample size is only 105 patients, and the majority, 65%, were in the context of post-LVAD patients. If you look at the success in weaning off of Protect Duo, the two studies from SMAC and Salna had very high rates of Protect Duo wean, but those cases were predominantly patients who had acute RV failure after LVAD implantation and were placed in the context of LVAD implantation, whereas the others were more of a mixed bag. But the wean rates vary based upon indication. In the non-LVAD patients, they're between 25 and 55%. Duration of support, to give you a flavor of how long patients may be on these types of support, usually they're around 2 to 3 weeks. In the case of the Oliverios paper, the range was much higher, and so that also indicates that this type of support can go on for a number of months, in fact. But if you put someone on RVAD support, it's not something that typically can be weaned in 2 or 3 days, which is what we typically had practiced a decade ago. We put patients on RVADs after LVADs and tried to very, very quickly get them off of it. But that seems to have been a mistake. And in the more contemporary era, we've come to the realization that the RV needs time to recover, and that can take a few weeks. If you look at 30-day mortality, the dots indicated in blue are the papers where the RVAD was used in the post-LVAD context, and you can see 30-day and 1-year mortality is less in the patients who had RVADs in the post-LVAD context, whereas in the mixed cohort, the mortality was higher at both 30 days and 1 year. Complications of Protect Duo are similar to complications related to any percutaneous large bore cannulation strategy with vascular complications. But in addition to this, the complications related to being so sick also rear its ugly head, such as multi-organ failure, stroke, and sepsis and major bleeding. So these devices are not without complication. The conclusion of this particular systematic review is that the Protect Duo cannula is increasingly utilized as an RV support device, despite the sparse retrospective data with variable patient characteristics. This type of percutaneous mechanical support is safe and feasible. So the data is still sparse, but it is encouraging. If we look particularly at RV failure after LVAD support, the pathophysiology, the framework for it, I like to use this diagram from an anesthesia review article on what happens after you institute LVAD therapy. Once you start the LVAD, you decompress the LV, and if you do that too liberally, in other words, if you try to turn the LVAD up abruptly and quickly, you can precipitate a leftward septal shift, and this is something, obviously, those of us who put LVADs in look at very carefully in the operating room. But if you do that, you will impair RV function. Turning the LVAD up, obviously, is our goal, but if you do it too quickly and too fast, you will increase the preload, also volume overloading the RV. This results in RA, RV, and tricuspid annular dilation, further exacerbating the problem by precipitating excessive tricuspid regurgitation. And all of this results in decreased left-sided filling, and the cycle then perpetuates itself and usually results in a suction event. And so we can actually precipitate RV failure more than the patient came to the operating room with if we manage this situation incorrectly. What do we do when there's catastrophic RV failure after LVAD implantation? Well, we do resort to using RVADs, as I mentioned before. This particular paper came out this year looking at right ventricular assist device placement during LVAD placement, and their conclusion was that it's associated with improved survival. This group out of Minnesota looked at all of their LVAD patients. It was a mixed bag, but predominantly HeartMate 3s from January 2016 to June of 2021. 395 patients. 19% of them, which 75 patients, had a temporary RVAD placed. 40 of them had them proactively placed. They had identified patients who they were very concerned about, and the proactive placement patients were usually intraoperatively with central cannulation, whereas the bailout placement occurred in 35 patients, and as you'll see, that was within a day or so, and these were predominantly Protect Duo patients. So the cannulation strategies were slightly different, but they were RVAD supported nonetheless. But importantly, there was a higher proportion of patients supported in this manner than was seen in the Momentum trial. And the reason for that is if you look at this particular study carefully, you realize that these were really, really sick patients in this cohort. The intermax levels were quite severe. Patient profiles 1 and 2 in the majority. A lot of these patients, 63%, had temporary preoperative mechanical circulatory support. In the proactive group, it was predominantly VA ECMO. And then if you look at the baseline characteristics of these patients, more than half of them were intubated going into their durable LVAD placement. And so this represents a very, very sick group of patients. They looked at all the typical parameters, and importantly, the visualization of the RV function, didn't really, wasn't entirely predictive. In other words, if they saw severe RV function visually, it didn't necessarily predict the use of these devices to a high degree, suggesting that the visual description of RV function is not the only parameters that you should look at. And importantly, the hemodynamic parameters that we just heard about, PAPI and the RA to pulmonary capillary wedge pressures in both bailout and proactive groups were quite similar, and they were bad, essentially. And so this was a very, very sick group of patients from an RV point of view. Postoperative characteristics. As I said before, the bailout strategy was predominantly peripheral, whereas the proactive group was predominantly central. If you look at survival, importantly, they showed that if you were proactive about it, you were able to improve 1 month, 3 month, 6 month, and 12-month survival. And so their conclusion was that proactive RVAD placement is associated with increased short and medium-term benefits compared to a bailout strategy in high-risk patients. And so they came up with an algorithm. If a patient's on VA ECMO coming to an LVAD, that they proactively put an RVAD. Otherwise, they looked for parameters suggesting moderate RV failure or low PAPI before putting a proactive RVAD in. Importantly, in an editorial, it was highlighted that this frequency of use of RVADs was much higher than in the Momentum trial. In the Momentum trial, there was about 3% use of RVADs. So this group was to be congratulated for their excellent outcomes in this very sick group of patients. But they highlight that these outcomes may be related to utilization of preoperative hemodynamic guided optimization and using a multidisciplinary approach, which brings me to my strategies for supporting the RV after LVAD implant. We talked about RV preload, RV inotropy, and afterload as contributing factors to RV failure. I talked to you about the pathophysiology that drives RV failure after LVAD implantation. And so taking this into consideration, preload, afterload, and inotropy, for me, what I do is I optimize preload by having my heart failure team admit the patient to the ICU for invasive hemodynamic monitoring, tailoring about 48 hours prior to implant. We volume optimize with diuretics or ultrafiltration, and we judiciously give volume postoperatively to a defined CVP target. We optimize afterload peri-implant with a low threshold to use prophylactic inhaled nitric oxide because that will directly reduce the afterload of the RV, and we use IV milrinone liberally with the added pulmonary vasodilatory effect. And finally, we are very conservative with our LVAD speeds. Initially, we target minimal acceptable speeds and flows to serve the patient's hemodynamic demands, to minimize the acute rise in CVP, to minimize the LV septal shift, and to minimize suction events that may damage the RV function. So in summary, RV failure can be secondary to a multitude of pathologic conditions, but is commonly encountered in the context of LVAD use. 1 in 3 patients has it. If you're going to use an RVAD, use it early, and I think that's the message out there. Thank you.